Okay, I think we can start. We are 2 minutes late, guys. Good evening, everybody. Welcome to KCash Global Education Forum. I'm Marco Mura, the Chief of Retina Department at King Khaled Eye Specialist Hospital, and I'll be chairing this session. Dr. Khaled AlSabti is with me. He will be moderating the session. He's a retina consultant in our division. He also will collect all your questions at the end of the lectures. We'll present also one case. We have a group of very esteemed guests tonight with us in this GEF from KCash. We have Professor Hassan AlDhibi from Cairo University. We have Dr. Faisal Fayyad from Jordan Hospital, Khaled AlSabti from Kuwait Specialized Eye Center, and Dr. Hassan AlDhibi from KCash. I would like to ask Hassan if he can start the presentation, and then from there we will follow with the next speaker and the question we will do at the end of all the presentations.
I just want to add that we will have some polls at a certain stage of the presentation. So everyone, I want you to be ready and to share with us your opinions once we reach that stage. Welcome, Dr. Hassan.
Yeah, thank you, Dr. Adil. Good evening, everyone. I would like, initially, I would like to thank you all to get this webinars and to get this really highly distinguished speakers to touch very important subject to us in the Middle East, the diabetes, and as you know, the prevalence of diabetes exceeding the limit, and Saudi Arabia by the time being is one of the high classes in diabetes. So in daily practice, we have our diabetic patient with their advanced diabetic retinopathy. So when we looking for what we are the most important for us to look for the result and the predictors for vitrectomy in these cases, and secondly, we can show and share you such cases that and how to be managed. So if you look for the Barca plan vitrectomy result in cases that having TRD involving the macula, 57% of the patient achieving visual acuity of 2400 or even better, while the patient who or having a non-macular TRD involving the macula, their expectation is high, reaching 84%. Visual prognosis depends in the pre-op visual acuity, in the patient age, location, and the extent of the traction retinal detachment, and duration as well of the macular heterotopia, as well macular ischemia and anterior segment, of course, neovascularizations. We did one study to look for this, the outcomes of and prognostic factors for vitrectomy, especially in chronic diabetic traction macular detachment, and involving 69 patients, and looking for that more than 91% of the patients were having really or had retinal and macular reattachment, and the visual acuity in 87.5% of these patients either stable or improving. So Barca plan vitrectomy in this patient usually is effective and need to be taking decision in the right time to get in this patient. This is where we have the visual acuity before vitrectomy and after vitrectomy, and you see in your right hand most of the patients were improved with really statistically significant p-value. And looking for the complication of vitrectomy in this patient, actually it's variable, but with the new system that microincisional vitrectomy surgery is that getting less and less, and most of the data that of the complication will contracted from the 20 gauge and old system that we had used it. So comparing our study with other, really we see that the patients really achieved good anatomical retinal reattachment and improvement in the visual acuity. Age and macular ischemia is the predicting factor for these patients. So what we have to look when we are doing our vitrectomy for advanced BDR, we have to look for the general status of the patient, including the blood sugar, blood pressure, anticoagulation, and dialysis. That's an important predictor as well for our patient. Ocular examination, visual acuity, intraocular pressures, anterior segment status, lens status, and dilated fundus exam. If that's coupled with fluorescent angiography, OCT is important. If there is no view, B-scan can really helpful in looking for what are the type of that we have, either just only vitreous hemorrhage or that associated with traction retinal detachment. Is it localized or really huge? Is it really could predict if there is possibility of combined rheumatologic detachment. Perioperative anti-vascular growth factor is an important really adjunct that really give us very helpful situation to control the bleeding during the surgery and make the surgery is safely going on. Consent is important to speak with the patients and to give him details about his status and looking for his expectations before surgery so that you can explain things in a good time before the surgery. Showing such case patient that young having such picture as you see bilateral fibrofast membrane covering the macula with vitreous hemorrhage in both eyes is really this patient is indicated to go earlier rather than to leave it later on. If you look for this patient, just simple vitrectomy and expectation in this case has been it will be tough surgery. So we started with cutting the anterior posterior component of the tractions, and after we finish that, we see that the possibility of the subhyaloid hemorrhage to be dispersed and making the view very tough. So you have to be patient, wait a little bit, start to evacuate that by either backflash using passive increasing pressure inside the eye, or using your probes to take out with high vacuum sections. This patient, if you look for that, it was easy surgery, and you look just only by using the probes that with the high vacuum and cutting that we are able to slough all the fibrovascular membrane after injecting anti-VEGF. If you look temporally to this macula, you find that the macula is starting to be elevated and that. So if you lift it for a long time, it might be lose the pupil of such patients. This patient, other eye, if you look, it is getting surgery 3 to 4 weeks after the first surgery, and see how things was a bit difficult in this patient when you compare it with the first eye done. So just only making, this is the fibrovascular membranes with subhyaloid hemorrhage at this area. Taking the blood was a bit difficult, but by the end I was able to remove it and starting to look for the membranes itself. See, now the membranes having epicenters and having really getting more adherent to the retina, and is not uneasy to just only peel it as we did in the first case. So with the time was taking and peeling the membranes from over disc, where is the strongest area, it might be give risk for bleeding, but easily it can be taking, this is the strongest area. If you go to the other area of the retina, it might be lead to retinal tear. So it's better to go from areas where you can do your job easily and make it. This is the end of this case, and look for the post-operative pictures. It's really showed that we are able to infiltrate disease just only with doing this vitrectomy that coupled with endo lasers. Another patient is having really long-standing traction retinal detachment that involving the macula and even with organized vitreous hemorrhage. When doing these cases, it is usually advised to be careful when you're taking the peripheral vitreous, because we don't know how much of the retina being tracked underneath this organized vitreous hemorrhage, and might be with while taking your anterior posterior traction component, you might cut the retina with you. So important to be a little bit careful when you're getting this. Now we are getting to this membrane. See how much is difficult. I'm using the probe, which is high ultra fit beveled cut that helpful to segment the membrane rather than to peel them. And by the end, ended this case without even retinal breaks, and retina being getting segmentations without using any timbrand, and was able to maintain the vision. This is the picture of the patient after the surgery. You see the macula look nice, while we are having residual membranes, but this has already been segmented, and the vitreous attached to this is being removed with good retinal photocoagulation. So we are maintaining at least the vision of this patient. One case that combined with retinal detachment, this is one of the tough cases. It might be just shallow combined retinal detachment, or could be high rheumatologist detachment with this fibrovascular, which is be difficult. So these cases is need to be careful when you're taking the membranes from the surface of the retina, especially with very adherent strongly to the retina. So you need to use your occutome to use it as retinal pick in the same times and removing the membranes. The retina is very ischemic and bit elevated, so exerting more power and traction in your elevating the membranes, it might lead to big break in this patient. So try to avoid it to minimize the much as possible the iatrogenic break for these cases. So taking these patients, and you see how much that membrane is removed, and then going to the macula, which is heteropic and being disorganized with these membranes, it's going to be removed easily, and you can adjust your mission in such patients. So this is where we have the patient then completed with putting perfluorocarbon and draining the subretinal fluid from the pre-existing breaks and applied your lasers. And in these cases, I like to go with more silicone oil rather than to be put gas in such cases. One more case. This is a patient, young patient, 23-year-old. He's presenting with advanced proliferative diabetic retinopathy with a lot of really membranes over his macula and active fibrovascularization over the disc and temporal to the disc, where laser applied and anti-VEGF applied just only 3 days before the surgery. And if you look for the fibrovascular membranes that being little bit less aggressive when you compare it to while the patient is presented, the surgery is, and his OCT, you see that how much is the traction exerted of his macula with a lot of systolic changes and macular detachment. The surgery done immediately, and the hyaloid was very adherent to the, and when you're doing corphorectomy, you couldn't find a lot of gel. So these cases need to be really giving specific attention, where you have to start and you get your dissection plane to start it. So I starting from the disc, just be elevated. You see the retina is very thin and ischemic. And after getting the opening, I starting to have the deliminations in block technique, which is a little bit modified, and then starting to use some segmentation with bimanual removal of the membranes, looking for the epicenters and the pegs at the surface of the retina, as you see here. Now starting the bimanual, cutting all the efficient. If you look for the superior part of here, the blood vessel were being avulsed and adherent to the fibrovascular membrane. So just little bit tractions, the break were created, which is really inadvertently. So endothermy applied and continue our bimanual dissections, taking all these adherent membranes. Doing peeling in these cases is really dangerous, so try to avoid it. If you look, it might be this patient having localized combined retinal detachment with subretinal band and this area. So it might be there was small tear at that area, but that is being enlarged with our dissection. So taking the epicenter and pegs from the surface of the retina, and by the end I was able to elevate the hyaloid in en-bloc modified delamination techniques and cutting that membranes. So ending by taking this small, residual membranes and taking to remove it from using both technique and using just only scissors. I prefer to use curved scissors to take this small residuals membranes and then take it. This patient were being putting triamcinolone to make sure that there is no vitreoschisis, and that residual could be lead to recurrency, or maybe that lead to the patient to have more recurrency of retinal detachment. Then do our air fluid exchange and put the silicone oil at that area. This is the picture of the second day post-op, and you see how generally the retina is looking, that restoring back the retinal shapes and with completely flat retina. So in conclusion, diabetic traction retinal detachment represent an advanced stage of diabetic retinopathy or progressions and retinal ischemia. Surgical intervention for diabetic traction retinal detachments is useful in vision maintaining and improvement. Visual prognosis depends on the preoperative retina status, intraoperative and postoperative complication. Surgical skills and experience are essential in dealing with diabetic traction retinal detachment. In the same times, I would like to say that you have to be effective, you have to be efficient, and you have to be proficient when you are dealing with these cases, as your intervention is making the traffic for this patient, either to getting lost the eye or getting the improvement or maintaining the vision. Thank you.
Thank you very much, Dr. Hassan. Very illustrative and very eloquent surgery. I appreciate you sharing your experience. Again, I'm going to remind you that we're going to keep the discussion later. Now we will move to the other presentation, the second presentation by Dr. Faisal Fayyad. Dr. Faisal, the screen is yours. You can start sharing.
Thank you. Thank you, my friends. You hear me?
Yes.
Yeah,
Loud and-
okay. No. Oh, okay. I was asked to present something in tractional retinal detachments in order, to cover almost all the subject with regard well by the end of this evening. My presentation, this is my first case. I tried to bring cases that are, not simple, not very difficult, just to give an idea what we can do. This is a tractional retinal detachment. There is no PVD. You can see here with aspiration, I created a window in the posterior hyaloid. And from there, I started my surgery. You can see here that I do everything with the cutter. Since I do a linear cutter, then as I aspirate and cut at the same time, you can see here that I aspirate and cut. I make delamination, segmentation, and delamination, and I start doing everything with the cutter. This is a case that I can do it just with the cutter, but there are other cases that is very difficult or almost impossible to do everything with the cutter. Just the cutter. Here it's possible. There is no PVD, and here I'm following the membranes with the anatomy of the membranes. Instead of starting posteriorly, I'm starting at the level of the equator and starting from there to do all my segmentation, delamination, but by the end of the day, I do everything, I delaminate everything. I don't leave anything on the surface of the retina. This is what is left, just over the macula. This 25 gauge vitrectomy, smaller is better in such cases. Here I elevated from the optic disc because it's safer. Then I finish the case with the cutter, as you can all see. Shaving. And since the macula was distorted, dragged down, I have to remove the ILM. It's not a routine thing that I do. Just once I see that the macula is dragged or there are wrinkles in the ILM, and I leave the eye with some air. This is my second case. This is a single eye patient, young man. He's in the early 40s. You can see here the ugly proliferation over the posterior pole. I segment, then I do delamination. I think it's much safer to do by manual surgery rather than with the cutter itself. You can see the retina is elevated, then you have to exert fair traction, not too much, not too little, in order to see the epicenters and delaminate to cut the epicenters. Slowly. Then now the other part, I separate the posterior hyaloid from the surface of the retina. I think this is, with the cutter alone, you can do it. Even if you do it, you might cut the retina, something that you don't want to do. That's why by manual approach in such cases is of extreme importance. You can see here, I just move the scissor face down, face up, in order to eliminate all the membranes over the retina. There is a tractional component, as you see there. I doubt that we can do this with a cutter alone. And now, of course, now we can do it with the cutter. Here, I did not remove the ILM, it's not needed, and just lift the eye with air. This is a little bit more complicated case, long-standing tractional retinal detachment with subretinal fibrosis, in my opinion, does not mean that there is a rheumatogenic component. Maybe it is just long-standing tractional retinal detachment that might lead to subretinal fibrosis. As the macula is detached, before going inside the eye, I have to make sure that there is no peripheral vitreous left. Once I go by manually, now with the cutter, I can do that with the cutter. And now I have to stop with the cutter because it's so dangerous to continue just with the cutter. There is some proliferation coming out from the fovea that I just cut. Actually, I encountered a few cases that there is proliferation that comes out from the fovea, and I continue my surgery by manually. In my opinion, this is extremely dangerous to do it unimanually, just with the cutter. Or it's not just dangerous, you cannot do it, in my opinion. You can see there is quite significant amount of subretinal fluid. I continue to delaminate. And here I need extra light from the nasal, from the temporal side. That's why you can see here, I just continue to delaminate, separating all this complex fibrovascular membrane, mainly fibrous membrane, from over the retina. Until I remove it all. You can see here, see some epimacular membranes left. I remove them. Now I go anteriorly. This is the macula. And I do anterior retinotomy in order to drain the posterior subretinal fluid. Then the eye is left with gas. This is my last case. This is 23 gauge. The previous was 25 gauge, all of them. You see there is severe tractional retinal detachment, ischemic retina. This lady, I think she was 29 or 28 years old. Here, you can't make mistakes. You can't make holes inside the retina. If you make holes inside the retina, you can't close the retinal holes, even if you use silicone oil or heavy silicone oil. Silicone oil, I'm not a big fan of using silicone oil in diabetic vitrectomy, but still sometimes it's used, it's needed, and this is how I do it. You can see the retina is severely ischemic, and there is a significant amount of subretinal fluid. I try in this case not to create any iatrogenic break. Creating any iatrogenic break, it means your surgery will not succeed because you can't close the retinal hole or the left retinal tear. That's why you have to be extremely careful once you do this kind of delamination, not to exert strength in peeling the membrane, but to be generous in pulling these membranes. to be able to see the epicenters and to cut them, to cut the epicenters. I don't know why I'm doing this 23, because I advocate 25 for all diabetic cases, but this is how it happened. It works nicely. And of course, in this case, it's very difficult to drain the subretinal fluid. And in my opinion, it is much safer just to leave it as it is. Like every case, diabetic case, at the end, I inject triamcinolone and peel what is left from the posterior hyaloid from over the retina. And this is how the eye looks like. I just lift the eye with air at 20% air, that's all. And this is how the retina looked like 2 months later. Thank you very much.
Thank you very much, Dr. Faisal. Very nice demonstration of how you would use a bimanual technique in those cases. I would like to ask Prof. Hassan Murtada to also share his experience and his presentation as well. Please, Dr. Hassan.
Thank you, Dr. Adil, for this opportunity, and I'm glad to see you even virtual, and hope to see you face to face in the very near future.
Inshallah.
Well, inshallah. I'm going to talk about the combined traction rheumatologist retinal detachment, and I think in some situations it is one of the most difficult cases to deal with regarding diabetic vitrectomy. I will start with a simple case. When I first saw this case, I thought it is due to a subretinal fibrosis, but it proved to be it's due to severe contraction of the posterior hyaloid, dragging the retina, cutting the retina, and producing this unusual configuration of combined traction rheumatologist retinal detachment. You can see that I'm using the probe, vacuum from the probe to detach the posterior hyaloid, because it's difficult to use bimanual approach here, because the posterior hyaloid is friable. You cannot catch it with the forceps. And then I proceed with the cutter. This is a 23 gauge cutter, which I like to use. And then following relief of the central traction, I also peel the internal limiting membrane after under PFCL, which helps to stabilize the retina and helps to make the dissection of the internal limiting membrane easy than when doing it with a mobile retina. The eye lamp is peeled as far peripheral as possible in order to decrease the scaffold for proliferation, and then the rest of the posterior hyaloid is peeled to the posterior board of the vitreous base. Using the chandelier and indenting for myself, I use also the probe to dissect peripheral fibrovascular proliferation, and then laser was applied, and there was only one break, whether this was the original break or it's an iatrogenic break, but this is the case at the end of the surgery. This is the second case, and I would like to demonstrate that in combined traction rheumatologist retinal detachment, again, you can use the vitrectomy probe alone without the need to use bimanual approach. And I think that using bimanual approach or the probe alone depends on how close the epicenters are to each other and how much the mobility of the underlying retina. Here, the vitrectomy probe is used to dissect, segment the membranes, use it as forceps trying to peel when there is a place to peel, and cutting the fibrovascular tissue, trying to go between the retina and the fibrovascular tissue and segment the membrane until you cannot do any more in this area. And then the probe is moved to another area, again, segmentation of the membrane, moving toward the optic disc. This is what we call the centripetal dissection, working from the periphery toward the optic nerve. And again, only the probe is used to dissect the aberrant posterior hyaloid and the fibrovascular tissue, inserting the probe under the between the epicenters, under the fibrovascular tissue, and cutting and segmenting the fibrovascular tissue in order to relieve the tangential traction. Here again, the probe is used, and then the forceps is used to pull the fibrovascular tissue from the surface of the optic disc. Here I'm working centrifugally from the center to the periphery. Here again, the forceps is used, and the cutter again is used to remove all the fibrovascular tissue. And remember, in spite of the mobility of the retina, still you can use the scissor, the vitrectomy probe to deal with the fibrovascular tissue, provided that the epicenters are not very close to each other and they are sufficiently elevated above the surface of the retina. And in these cases, I would like to remove the internal limiting membrane also as peripheral as it can be done in order to remove the scaffold for proliferation. This is a more difficult case where there is a circular contraction of the fibrovascular tissue producing combined tractional rheumatologist retinal detachment. And first you have to segment this circle, because if you are going to work bimanually, then you do not want the traction to be transmitted to the other areas of the retina. So I divided this circular traction, and then using bimanual, because as Dr. Faisal said, you reach a stage where you cannot proceed with the unimanual surgery, and you have to use bimanual surgery. Again, this is 23 gauge scissors and forceps, and using the chandelier light, the traction from the forceps is used to expose the epicenters or put the epicenters on stretch so that they can be cut with the scissors. And you have to take care that vitreous schisis is a common feature in these eyes. So you have to find the correct plane. The videos are not working?
It's working fine. It's working fine.
Okay. And then the scissors can be used as a spatula in order to sweep between the posterior hyaloid or the fibrovascular tissue and the underlying retina. So the scissors can be used as a spatula. It can be used as scissors, both vertically cutting and horizontally cutting. Here you can see that there is an area of vitreous schisis. Then triamcinolone is injected, and usually there are remnants or epiretinal membranes or remnants of the posterior hyaloid that has to be removed, and then brilliant blue is injected, and in combined traction rheumatologist detachment or even complicated traction retinal detachment, I like to peel the internal limiting membrane, whether you do it without or better under PFCL to stabilize the posterior retina. And this is followed by shaving of the vitreous base into laser. And I stress you have to laser the retina intraoperatively, and the laser should reach to the level of the aura. This is the third case. It is a more severe case of combined traction, rheumatologist retinal detachment. Even it looks like a case of PVR with a narrow funnel, but still it is old standing combined traction rheumatologist retinal detachment. The probe is used to detach the stalk from the optic disc, opening the funnel. Also, there is no place here for bimanual surgery. You have to depend on the vacuum from the vitrectomy probe in order to detach the posterior hyaloid or the stalk or the fibrovascular tissue from the optic disc, and then working from the center to the periphery. And I think that the best way to find the correct plane is to start dissecting from the area of the optic disc or in the peripapillary area. PFCL is injected, and then again, you are obliged to use the bimanual approach in order to remove the posterior hyaloid. But in this case also, the posterior hyaloid was strongly adherent, it was transparent, and the underlying retina was severely ischemic. Actually, this patient lost the other eye from following the vitrectomy for diabetic complications, and she was afraid of doing surgery on this eye. So the detachment was all standing, but this was her last eye. And again, here I'm using the vitrectomy probe and the forceps, which is another way of using bimanual. So you can use forceps and scissors, or forceps and vitrectomy, small gauge vitrectomy probe. And the dissection is carried on from the center to the periphery. And you can see that the posterior hyaloid here is transparent, thin, friable, and so you have to catch from the area where there is fibrovascular proliferation. And the key is to clean the retina completely. There is no place of leaving any remnants of the fibrovascular tissue on the retina. So the aim or the target is to clean the retina completely, not leaving any fibrous tissue attached to epicenter. The vitrectomy should be performed, and then again, in these cases, I like to peel the internal limiting membrane to remove the scaffold for future proliferation, which is common in these cases. And this is the end of the operation. This eye was filled with silicone oil. This is how to show you how, in this, again, difficult case, the bimanual approach, this case cannot be operated except with bimanual approach. I have segmented the membranes, but at the end, you have to use the bimanual technique to remove the fibrovascular tissue. This was carried on again from the center to the periphery. Here, the bimanual approach can be used to remove clotted blood over the surface of the retina, which may be difficult in some cases because it acts like a membrane over the surface of the retina, and here the blood is stuck to the surface of the retina, and you have to remove it bimanually. Still, the only way to deal with these cases is the bimanual, using the bimanual surgery, looking for the correct plane, and until the whole tissue is removed, and then it is removed and PFCL is injected to reattach the retina. Still, there are still posterior hyaloid adherent to the retinal periphery that has to be removed, and then the eye lamp is peeled, and I think it is mandatory in these cases. I think this is the last case. It's a combined traction rheumatologist retinal detachment, and again, I started the dissection from over the optic disc, and the tissue over the optic disc is directly coated with the forceps, and then working from the center to the periphery with the small gauge vitrectomy probe, segmenting the tissue, and of course, using it as a cutter and as a spatula, finding the correct plane for the dissection until you reach a stage where you cannot continue, or you should remove the blood whenever it is collected over the surface of the retina and cauterize gently the bleeding points in order to prevent blood from accumulating over the surface of the retina. Again, here you have to use bimanual approach with the scissors and forceps, using the scissor to push the retina with the back of the scissors and exerting traction with the forceps, creating, making the epicenters more obvious, and then cut the epicenters, and taking care every now and then to decrease or debulk the fibrous tissue until it is all removed from the surface of the retina. And again, you have to inject even using the probe in order to dissect this sheet of posterior hyaloid adhering to the underlying retina. And then this, I think, the last piece of the fibrous tissue. And again, in these cases, I think it is mandatory to remove the internal limiting membrane to smoothen the macular area and prevent future reproliferation. And again, laser is applied up to the ora serrata using indentation under the chandelier light. This is the last slide, and I recommend not only doing laser to the area, to the retina, to the equator, but to have the laser applied up to the ora serrata, because this area is probably ischemic, and this may be a reason for new vessels proliferating over the periphery of the retina and even over the ciliary body, producing recurrence of vitreous hemorrhage, and in some cases hypotony, and in others the proliferation behind the lens. Thank you for your invitation and for the opportunity. I'm very happy to see you.
Thank you very much for this very nice videos that you've shown. And there are a lot of questions, but we're keeping them to the end, so we can also have Dr. Khaled also participate with us. I'm sure he is eager to argue about what others say about the subretinal fluid drainage. Dr. Khaled AlSabti will be talking specifically about when to drain subretinal fluids and TRTs.
Okay, thank you very much, Abdallah, and hi everyone. It's really an honor to be with great surgeons. I'm really learning a lot from you. I'm just going to talk about the how to handle the subretinal fluid. As Dr. Faisal said, he showed one of his cases where he did purely TRD, not a combined, and there is a significant subretinal fluid. And as you know, with the advanced technology and an instrumentation and perhaps good surgeon skills, we probably don't create intraoperative breaks or iatrogenic breaks, and may end up with significant fluid. And at the end of the surgery, sometimes we scratch our head whether we should drain or not to drain. After doing all great job preventing any breaks, why should we go and do a break? Create a break to drain, which...
Sorry, Doctor, sorry, Khaled, because Hassan AlDhibi is still sharing the screen. Can you unshare, please? Otherwise, we cannot see your presentation.
Yeah, sorry.
Okay.
Up and right, where you are seeing, this is still the screen of Dr. Mortada.
Okay, I'm sorry.
Yes, perfect.
Yes.
Okay.
Dr. Khaled, yeah, can you share your screen?
Sure. Yes, let me get back to my video. All right, I'm going to show...
You have to share your screen, Khaled. There is a green, yes, great.
Okay, good. So let me show you this. This is a narrated video. I hope you can hear it.
Put it in presentation mode, yes.
With significant subretinal fluid. This 48-year-old patient with diabetes over 30 years presented with significant drop of vision in the past 3 months due to tractional retinal detachment. Despite having
I'm not seeing the videos, guys. Do you see the video?
Yeah, it's stuck. I think if you could, if you can stop the presentation mode, then then go to it again. It's stuck in between.
Okay, so what should I do? Stop sharing?
No, stop the presentation mode on your presentation. Or is this a video that
Just a
you're showing?
video.
Okay. Okay, maybe you can close it and turn it on again maybe, and don't share your screen. Share the video directly, not the screen itself.
Oh, okay.
So press share screen. It will give you multiple options. One of them is actually the document you want to use.
All right, so sharing. Okay.
The green button at the lower end of your screen. Just stop sharing and share again. Maybe you'll get it this time.
Okay, so let's go back again.
You need to have the video opened on your screen so you can share it.
Okay, so. Can you see it now? No?
No. No, you still need to share it.
Okay.
So again, share screen, and then from there you can choose the file itself.
I'm trying to. Share screen, okay.
Nothing.
Share. Can you
Okay.
see?
Yes.
All right. Tractional retinal detachment with significant subretinal fluid. Can you see it?
Yes.
Diabetes over 30 years, presented with significant drop of vision in the past 3 months due to tractional retinal detachment. Despite having significant tractional membranes, we can perform surgery without inducing any breaks in about more than half of the cases. As you can see here, with smaller gauge vitrectomy, membrane separation and dissection is performed meticulously without inducing any breaks. We should be very careful when peeling off the hyaloid not to induce retinal breaks. Occasionally, we need to rely on other instrumentation like scissors. However, with smaller gauge vitrectomy, our need for scissors becoming less than before. Towards the disc, the membrane becoming thicker, and there is a chance of causing retinal break at this point. So we have to be careful. Another instrument sometimes is needed to perform complete membrane dissection or separation. Although most of the membranes is being peeled using the cutter, as you can see here, I needed a forceps to pull the posterior thick membranes from the disc and from the macular region, and therefore the membrane was removed and trimmed with the cutter afterwards. This patient had significant subretinal fluid, the highest on the nasal side, where I decided to drain. To avoid creating retinal retinotomy in this case, I decided to go transcleral to drain the residual fluid. As you can see here, 27 gauge needle is pushed in the subretinal space through the choroid, and the needle was seen in the subretinal space. The bevel is directed towards the choroid to prevent retinal incarceration. As we drain subretinal fluid in a passive way, we have to increase intraocular pressure in this case. As you can see, the fluid is being removed slowly and gently. Here, the last drop of fluid is being removed, as you can see, and at the very end, we pull out the needle without causing any retinal or choroidal damage. While keeping the intraocular pressure at 60, the needle can be pulled gently to prevent bleeding. Once subretinal fluid drained, air fluid exchange is performed. Since we did not have any retinal break, the eye was left with air only. As in this case, we can leave significant subretinal fluid in the eye. However, visual rehabilitation may take longer. That's why we decided to remove subretinal fluid. Finally, endolaser was performed. Thank you for watching my video. Good. So as you can see here, This is the case where I did not get any iatrogenic break, and then I had to. Can you hear me?
Yes, yes, loud and clear.
Yeah, and we sometimes face this problem. I remember Marco Mura at Retina 2017. He did a extremely difficult case where he did a great job not creating a break, and then he ended up with a lot of fluid that he left behind, and he couldn't do a lot of laser. So there is always an argument whether we should drain and we should not to drain. And I think I have done so many cases with transscleral drainage, whether active or passive, and I'm so confident that we can drain most of the fluid, whatever the case is of a detachment, and prevent having, especially in a very significant or bad diabetic, where you don't want to have this fluid wandering around for a long time, and you just, every time you see this patient with fluid, you don't know whether there is a break or what you're dealing with. So this is just, I thought that I wanted to share with you. I have another case that is about dissecting membrane using a cutter, not to use the scissor if you want. If you have time, it's 2 minutes, or you want me to stop here?
I think just for the sake of time, maybe we'll have a chance to add some of your cases at the end. But I would rather move the mic forward to Dr. Marco Mura, who would also share his experience in those cases. Dr. Marco, are you there?
Oh, hi everybody. Yes, I'm with you.
Thank you, Dr. Khaled.
Very nice technique, Khaled, by the way. We can discuss it later. I think there will be a lot of questions about this. But
I'm already getting a lot of these right now.
Khaled, can you unshare your screen?
Oh, okay.
Otherwise, we cannot go further.
How?
So just from this, the same button you shared the screen, just press on it, and it will immediately stop.
Okay. And stop sharing. Okay. Good.
Okay, so let's see. Let's share screen. So here we go. Let's see.
Hello.
Okay. Can all of you also switch off the mute yourself?
Yeah, I'm doing it right now.
Okay, I will stop my video. Otherwise, the video is slower.
Yes.
Oh, great. I do presentation mode. So I will do a little summary here because we saw everybody show beautiful videos, and basically we saw different types of diabetic tractional retinal detachment. This was a great example to show you all that there is not only one type of diabetic tractional retinal detachment, but there are several types. As you can see here, this is basically a kind of proposed classification of it. You can see in the first image on the left, upper left, that there are a simple diabetic tractional retinal detachment where you have a single focal point of adhesion, and these are very easy to address. You can do this very easily with cutter only, with unimanual technique. You don't need to have a lot of armamentarium with you. The bigger becomes the adhesion between the retina and the posterior hyaloid, the broader it becomes, the more complicated becomes the surgical procedure. If we call this stage 1, we can call this stage 2, where you can see larger, broader adhesions between retina and fibrovascular tissue, which are more difficult to address. And we saw several examples of this. If we go further, we can call this stage 3. We can see how these adhesions are really even broader, and the retina start to detach more and more. In these cases, it start more complicated procedures, and it's more difficult to address these cases only with the cutter only, because before there was a question in the panel, when do you use cutter only in manual or when you use by manual? Definitely, if you have broad adhesion, I think it is safer, especially in a context of ischemic retina, where the retina is very thin and mobile, to address these cases bimanually. In the stage 4 is exemplified here. You can see that this adhesion not only are broad, but they are also low-lying, and the posterior hyaloid is totally attached with very little cleavage plane on the posterior pole of the retina, which become even more in the stage 5, which is the one on your right, where the hyaloid is totally stuck from the posterior pole to the peripheral. These are the most difficult cases. Usually the retina is a low-lying detached with the adherent hyaloid, but once you start removing the posterior hyaloid, the retina starts to become very mobile, and most often you have also rheumatologist component of, if it's not there, you will be creating it because it becomes a very complicated procedure. Okay, so what is going on here? Okay. Another way of classifying it is not only based on the adherences. We saw that several examples, there were some of the cases that were very good vascular activity. Some other cases we showed that were very ischemic, that they showed us were very ischemic. So I think even the vascular activity is extremely important. Also, once you are going to deal these cases with preoperative avastin, I think the amount of vascularization present in these cases is important. If you have a very avascular or involuted type of fibrovascular tissue, you really don't need to have probably avastin injection, like in this case. It's white tissue with really very little blood vessels there. Maybe or if you need it to have it with a very little timing between the surgery and the pre-op avastin. Maybe 24 hours would be sufficient. Once you can have also this vascular activity can be mild or moderate. You have some examples here where you see the blood vessels running really through this fibrotic tissue. And in these cases, maybe it's mandatory to have the anti-VEGF a little bit earlier, maybe 4 or 5 days before. And then there are cases like this one where the vascularization, the vascular activity of the case is very severe, and you need really to inject probably more than 7 days to have a complete resolution of this activity before having surgery to avoid bleeding. This is, of course, something which we see in the practice. There is really nothing much published about this, actually. Maybe Dr. Arevalo later can comment about this. We saw it in our panel. We published very well about this topic. All of us, all the speakers, they spoke about the goals of diabetic vitrectomy. The goals are to remove all anterior, posterior, and tangential traction. And in doing this, we have to try to minimize or avoid, if possible, iatrogenic retinal breaks. We have to try to maintain hemostasis. Remember that every time you are doing a diabetic case and it starts bleeding and you have still posterior hyaloid attached, this becomes like a glue which sticks on your tissue and can be very difficult to remove it if you don't do it very quickly. So if you try to do these cases, remember it is mandatory to try to do it with less blood possible to make it more efficient. Otherwise, this blood will become like an extra sheet, an extra member that will need to that adheres on the surface. You will need to remove also. And of course, preventing recurrences is the key. And if you choose the proper technique and the proper management of the patient, you will be ending up having good results. So there are several ways of removing traction. We saw, I agree that you have to remove all traction. Nowadays, I used to start doing segmentation. Nowadays, I use the segmentation only to get access to the surgical plane, but I really do not leave, I don't like to leave any fibrovascular tissue left in place. So everything has to go totally, all the posterior hyaloid has to be removed. Of course, you can do this in only manual way. I think nowadays with all the instruments we have, it creates only more complicated situation, and you can do for sure in the simpler case, the stage 1 or 2s. But by manual dissection is for sure the way to go. With the help of a chandelier. This is what we usually do when we have focal TRDs, as I told you, with non-rheumatogenic components, stage 1 and 2, sometimes stage 3. We try to do this with the vitrectomy probe because the cutting port, as all the speakers show, is very close to the tip. We can really go with these small cutters, sometimes 25, 27 gauge. We can go behind the spherovascular tissue and really cut away the fibrosis. I really need to be careful doing this when the retina are ischemic and when the retina are mobile, which can happen in cases for sure of combined TRRDs, but also in cases where there is no rheumatogenic component, sometimes can be floppy. So in these cases, I still prefer scissors, and I still prefer scissors with larger gauge, 23 gauge, because they offer a better surface of grip and allow you to dissect better. As I said, the segmentation nowadays, I use it to get access to the surgical plane. And when the TRDs become more complicated and there are large adhesion, I prefer to do the surgery bimanually. It can be bimanual with forceps and scissor, or bimanual with forceps and cutter. We will see some example of all of this. These are two types of dissection. I'm not here to teach you this. Most of you know it, like the so-called fold-back delamination. We see some example of this. Like fold-back delamination is basically when you put your cutter above the membrane, the fibrovascular membrane, and you see the fibrovascular membrane folding up on your port. This works only when the fibrovascular tissue is not really stiff, when it is not really mature, because otherwise if it's too stiff, it will not fold into your port. And in this case, you have to use the so-called conformal delamination, which means basically applying the edge of your cutter on the rigid part of the membrane with your tip pointing up towards the membrane itself to avoid the iatrogenic break. So we can see also another extremely important factor, I think, nowadays in this type of surgery is visualization, especially if you have the chance of having a 3D system. I would really kindly advise you to use it in the setting of diabetic tractional retinal detachment, because really allows you to have a much larger magnification. And if you use this together with this wide field, a new type of wide field lens, you will have a beautiful view during your surgery, with magnifying all the details, and will allow you to do a better, more careful surgery, which means reducing a complication. This is an example of a case. You see there is a circumferential traction, a very large, broad adhesion. Retina is detached, is not low-lying focal detachment, but it's a broad case. So one of those stage 3s I showed you before, maybe stage 3 to 4. I'm doing this case with a constellation and with the Ingenuity system. You can see there is some amount of blood and the image is quite blurry. If you, in this case, put the hemorrhage filter of the machine, you can see the image becomes more clear. The fibrotic tissue is much more evident, and this redness disturbs you less, so you can do the surgery in a much safer way. You can see that you can appreciate better the planes with the hemorrhage filter than the normal view, and you can do the dissection in, as I said, a much safer way. You see how much I magnify. I don't tend to magnify. Actually, it's impossible to do this with an analogic microscope. But if you have an Ingenuity, you can really magnify the field where you are working. And you can see really much better what's going on. In this case, we cut and segment the circumferential area, as Dr. Mortada showed us very nicely, because I think you have really to avoid to, as he said, to widespread the traction in the areas next to where you are working. And then we can go in these soft membranes to remove it with a backfold delamination, put in the cutter, very high speed, as you can see, actually I vacuum above the membranes, just touching the membrane from the top, and this membrane will go into the port of your cutter in a very efficient way. Without having any problem, especially in this area while the retina was not too mobile and was not very high rise detachment. You can see here the retina is very ischemic, but still, because it's not too much, there is not too much fluid and there is not much mobility in the retina, you can do this maneuver very safely with the cutter. And once the cutter is not enough anymore, because the retina is more detached, or because the cleavage plane, I think, is more tight against the retinal surface, you need to go bimanually with a chandelier light and really going with one hand, holding the membrane, lifting it, exposing the fibrovascular attachments, and dissecting it, as I'm doing here with two hands, slowly from the retinal surface. Here, the cleavage plane was very tight. There was no other way for me to do this in a safe way, avoiding breaks. So I decided to switch for bimanual and go ahead with the dissection bimanually, as I'm doing in here. At the end, we managed to remove everything without any breaks. We cut the peripheral vitreous and we do the laser. So next slide. This is another case. As you can see here, thin retina, ischemic retina, but mostly concentrated on the posterior pole of the eye. So there is, I'm here truncating the posterior hyaloid and the periphery. Remember, all these cases, they have most of them vitreous cases. So even if you think you are truncating the posterior hyaloid, then afterwards you always have to go with transinolone to check if really the posterior hyaloid is gone or if it's still there. And then, as I said before, when there are large membranes, can be circumferential or tangential, I always like to segment them first. This is what I said before. I use a segmentation as an access segmentation to basically go inside and find the cleavage plane, hold with one end the membrane and dissect bluntly or sharply with the tips of the 23 gauge scissors, in this case, the membranes. As I said, I like the curved horizontal 23 gauge scissors. This brand is from Dork. I like them very much, actually, because you can use them as a spatula also. You can really move the membranes around and move the posterior hyaloid like a spatula, because of the conformation, and the shaft of the scissor is really long, and that's why it allows you to do this. There was some fibrovascular tissue directly going into to the fovea, which needed to be removed, and I'm doing this dissection up to the periphery. You see the retina is very, very thin. It means it's very ischemic, so very thin. It means you need really be careful to avoid iatrogenic breaks. We didn't do it, but as I said, here you see there is still some subretinal fluid left in place, which I don't like to drain. I don't like to make posterior retinotomies. And in this case, I must say, even the technique of Khaled would not have worked, because the fluid is only posterior. So I cannot really drain it otherwise. It just needs to stay. This is another case. There is a phaco. I will go further. I don't let you see the phaco part, sorry. So this is the case, as you can see, sorry. It's quite complicated, very ischemic retina, totally adherent hyaloid, tractional rheumatologist retinal detachment. In this case, there was no way to enter this fibrotic mass, so you have to create some space. And to do this, I like to pull from the disc, if I can localize where the disc was, to create some space, then making a keyhole inside. And once you have the keyhole, you can slowly try to dissect bimanually with the scissors first the tissue to understand a little bit the anatomy. You see the retina is folded in several folds. There is not the only one. There are several, one after each other. So you have to really be careful in this dissection. All these broad membranes need first to be segmented, and then slowly blunt dissection or sharp dissection with one end of the tip, to remove the adherences between the retina and the fibrovascular tissue. As you can see here, the cleavage plane is very tight. So there is no way to do this with the cutter only, because the retina behind is very thin. It's very thin because very ischemic, and it is actually mobile because of the rheumatologist component, and the cleavage plane is very tight. So there is no possibility to get in without creating breaks, which, by the way, you can see there, it's already one happened during the surgery. It's almost impossible to do it without any iatrogenic breaks. It's really, you need to be very lucky to do that. You can see the amount of the extension of the fibrosis. It goes up to the pars plana. And you really need to remove all this tissue if you want to have a successful surgery. Otherwise, you will have recurrences. You see, I'm trying to do an access segmentation, just opening the hyaloid slowly up to the ora serrata in a radial way, and then going tangentially to separate it bimanually with blunt maneuvers from the retinal surface. Once you manage to separate it, you can remove it with the cutter, of course. And but this is very long and time-consuming procedure. You see the retina is very ischemic, so it doesn't really bleed too much, even though we did, of course, Avastin before, but due to the ischemia, here is not bleeding too much. I go a little bit further for the sake of time. I put some, when the retina is so mobile, I put some heavy liquids to stabilize posteriorly, to be able to work more in a safer way anteriorly. And all this hyaloid needs to be trimmed and removed as much as you can, otherwise it will contract and it will give rise to a very bad PVR detachment. Really, you need to do a very thorough job here. But this surgery at the end can be really rewarding, at least from an anatomical point of view. We are using here the articulating laser to do the periphery. It's very handy when you have a small gauge, because it allows you the instruments not to be flexible. And here you do all the laser. I also agree you need to do the laser totally up to the ora serrata. There is no way you leave any space free when you do this type of procedure. This is another case, I think is the last one, also a young patient, very bad fibrovascular proliferation, TRRD, especially in the temporal side, in the nasal side, sorry, which is the more difficult part. Also here, very difficult. Trying to find the cleavage plane can be tough. You have to go very slowly. Once you find it, you just go ahead and start dissecting. You can see the more you dissect, the more the retina becomes loose. I'm using here a 25 gauge pick with light to dissect the hyaloid from the peripheral area. Sometimes this is an instrument that can be helpful. If you think your scissors are too sharp, you can use an illuminated pick and it helps to dissect the vitreous from the periphery. Then you put some perfluorocarbon as usual to stabilize posteriorly, and you trim and you dissect the hyaloid again posteriorly. Very important to remove the membranes also posteriorly. Sometimes you need to do it under perfluorocarbon because the retina is very mobile. And also here we have, I go further. We have also some subretinal membranes, which I needed to remove. It was very old, long-standing detachment. But at the end, after removing all the membranes, we managed to flatten the retina and we tamponate with silicone oil. This was my presentation. Thank you very much.
Thank you, Dr. Marco, for this nice presentation. Very tough cases. So before we open the floor for discussion, I would like to have you guys all interact with us in your experience. I'm talking about the attendees. So I'm just going to show a quick case, and I want step by step to get from you your experience. How would you deal with those cases? So I hope my screen is also clear to you guys here. Dr. Marco, you see this screen?
Yes, it's clear. Yeah.
Okay, excellent. So the first question I'm gonna address here is in the polls, if I may, just 1 second. Okay, so please, I want you all to participate. When do you usually give your pre-op Avastin? Would you give it 1 to 2 days before the surgery, 3 to 5 days, or more than that? And we'll move a little bit forward with the case. I will give you up to 30 seconds and then we will close. Okay, so moving forward. So this is a patient that, this is something that I want all of you to address later on, about how would you use a chandelier. There are many options in the market, so maybe we can have this discussion. Dr. Faisal, I've seen you use bimanual technique in some of the cases. Do you have any certain preference in terms of what you use for chandelier light?
Usually I like chandelier light. I can't see in all my cases. I would love to have it in all my cases. I use it routinely in all my cases.
Okay, excellent. So
because you know, once I shave, even in simple cases, I just press and do shaving myself. Yeah. Nobody can help you like yourself.
Yes, exactly. So back to the poll, we have most of our attendees giving their injections 3 to 5 days before the surgery. Okay, moving on with the case. So as you can see here, I've chosen to use our makeshift chandelier light that we use in our our hospital. This is a Dork chandelier bullet light that we typically use for maybe for its effectiveness, and it's also for a financial reason as well.
It's actually great. It works very well, especially if you put an inferior nasal quadrant adder, as we all do in K-Cash. It's actually great.
One of the options as well to add one trocar in the nasal sides, so that you can shift light and the infusion. So if you need to move, it's give you the flexibility in the surgery.
Okay, excellent. So I'm gonna also want all of you guys attendees to share your experience. How would you deal with bimanual cases, or how many of your cases actually are bimanual? Do you do all of the patients who are diabetic, or you choose only those who have traction? Specifically, do you choose those who have broad traction, or you never use chandelier lights? I will give this another 30 seconds. Okay, moving forward with the case. So this is a patient who had a traction, retinal detachment, broad adhesion. He's pseudophakic, as you see. And as soon as I start my case, I run into problems here. I created a break. So Prof. Murtada, I see that you are still with us, but I can't see you on the screen. I would want to know your opinion generally in those cases. So we try to do as much as we can to prevent having breaks in those cases. But once you're in this situation, you have a break in the beginning of the case. Do you change your settings? If you can see, I'm having my settings here at generally high numbers. I keep my my vacuum at 500 or higher, and then I adjust from my foot pedal. Would you change your setting based on how the retina mobility is?
Let me say first that creating a break or even few breaks does not mean that the case is a failure. So all of us are subjected to creating iatrogenic retinal breaks, especially when the retina is mobile, ischemic, in the combined tractional rheumatologist retina detachment, and even with the traction retina detachment. So this does not mean the failure, the case is failed. I think that the best way not to create a break is to concentrate on what you are doing from the beginning, very beginning, because creating a retinal break usually occurs when you lose for seconds the concentration. So you have to predict how the underlying retina or the retina you're dealing with is moving. And so you have to judge this from the very beginning. So I don't usually change the settings. So the settings are fixed on the machine. I use the foot pedal to control the vacuum. The cutting is at the highest on the machine, which is now 750. And so
650.
I think, sorry?
And the vacuum is the maximum, my understanding,
Yeah,
right?
the vacuum is 500 to 600. And
So you're not a big fan of the shaving versus core vitrectomy principles that we hear.
Yes, I think that this type of surgery needs a lot of concentration in a quiet room, and you have to, as I said, to predict how the retina is going to behave, and this is based on knowing the pathoanatomy of the pathology you are dealing with. So,
thank you very much. Okay, so we'll carry on. As I told you, most of our attendees would use the chandelier in broad traction, and I can see that more than 78% of our attendees are actually advocating using bimanual technique, which is a very good thing. Very good thing.
Question, because we saw basically, I think all of us are using Alcon machine, which we know it's a proportional vacuum machine. But Dr. Faisal uses I think it's BNL, and I think he wants to comment. Do you really think that this dual linear has an added value in these cases?
Absolutely, it is an added value.
Why?
I find it very comfortable. Once I do unimanual surgery, it's very helpful. You know,
why do you think that? What do you do differently?
You aspirate and cut. You aspirate and cut. And that is very helpful. I think not just BNL have it. I think DORC has it as well. Has this facility as well. Other machines has it as well.
So you use it basically as an extra instrument because you grab the machine, grab the tissue, and then you cut it basically.
Absolutely, absolutely.
Okay.
You aspirate, you grab it, then you cut it. That is, I think, very helpful. Having dual linear, you can, it depends. I keep, aspiration and cutting rate fixed, and I do everything with the foot pedal. If it's posterior, if it's delamination, if it's shaving, because of course, once I go very anterior in shaving, especially if the retina is mobile anteriorly, aspiration has to be less, of course, has to be less. And this is adjustable with the foot pedal.
Okay.
Great. So moving forward, I just want to ask another question. Maybe I did not address this earlier. Talking about combined surgery, Dr. Marco probably showed some couple of cases where he had phaco with vitrectomy. The question is for all participants. My question is, when do you do phacoemulsification? You don't perform any phacoemulsification, or do you do it before placing the trocars? You do them after placing one of the trocars or after you place the infusion cannula? I would like everyone to share their experience. Maybe something like this would be useful for people to know what others are doing as well. Okay, so moving forward, yeah, so this is a case where I started cutting using the cutter, and then I went to start using bimanual technique. In here, I started to cut from outside in, or counter. What was the term used, Dr. Murtada? Centrifugally, and then coming from outside to inward. My question is here to Dr. Khaled AlSabti. Do you advocate always doing an inside-out approach to the dissection, or you do outside-in depending on the case?
Well, it depends on the case. Sometimes you prefer to go inside out, or sometimes from outside in. In a case where there is a thick, very thick membrane and you think you may induce a break, I prefer to go from outside in, and I always leave the most difficult part at the end, because you don't want to have break in very beginning of the case. You will end up having a bullous detachment, and this will complicate the thing, and maybe you put perfluoro, and really it's going to be very difficult. Try just to do the easy part first and leave the hard part last. And it depends. There is no two cases are the same. I think everybody agree with me that even in the same patient, right eye is different than the left eye.
Absolutely. Okay, so going back to the poll, we see that almost equally the people are doing the phaco in terms of the stage of the surgery where they will do phaco.
It should be specified here. This is not, of course, phaco in combined or in diabetic cases, Adel. I mean, that was a bit unclear here, right?
Oh, okay, sorry. It's in combined, so you're doing phaco vitrectomy at the same time. When would you do it? I mean, in terms of the surgery itself, not in terms of sequential or combined at the same time. I'm talking about someone who's decided to do the surgery for him. So basically, we almost have, I mean, 30-30. And going back to this case, you see that I started to get some bleeding here at the disc, but probably I felt that I can go more with dissecting the membranes as more and more. I mean, to progress with the surgery. And then my question is, when you start the surgery, you dissect usually coming from the disc, and then you come outward. You kind of get sometimes those bleeders at that stage. When do you start using the 60, or you raise the IOP and start working under high IOP? I will ask Dr. Hassan AlDhibi this question.
Yes, bleeding could be expected any time, so you have to be ready before the surgery, that you have your diathermy beside you, and when you're encountering bleeding from the disc, the first thing that you have to think to elevate the pressures immediately. Be careful, sometimes we are working in such case like that, you might forget. So that ask your assistant to be careful. I need it for 30 seconds, 40 seconds, or 45 seconds. So that's the important. The other things, just only keep the pressure a little bit high, keep not working until a little bit. Make sure these cases might be ended by corneal, epithelial edema, and you have to continue your mission to clear up that epithelium or to take it out. But this is the things that as you.
So Dr. Hassan, what's your usual setting starting a diabetic vitrectomy case in terms of the IOP?
Yeah, putting in your mind, this patient already they have an ischemic, component. So usually I put it in 30 millimeter of mercury, usually, and up to the situation I increase it. And looking for the disc when you are working, sometimes you're seeing the disc is pulsating. If it is pulsating, that means that your pressure is exceeding the limit. So it's trying to put it back. when you encounter bleeding at any time, so that you have your that your means is increasing the pressure and starting the diathermy if the blood vessel just away from the disc.
Okay, another question. So now moving forward with the case, I'm injecting triamcinolone here.
I cannot see your case at the surgery.
I'm sorry, then I have to go back.
I would like to add one comment for the previous talk. Remember that you are the one who's doing the surgery, is not the machine. So when you remember that, so that use the machines to help you. So every case that having like it's not the same as having the same approach. So to select your cleavage plan, is it from the disc or from the periphery? It depending in the case. Increasing the pressure, I mean that the vacuum, or increasing the cutting rate depending in the membrane that you have it. Sometimes membrane is easy shut, as the Dr. Marco show that you can, this membrane is fragile and the retina is stable, so that you don't have to go with, you don't have to be scared about, cutting the retina. If the retina is mobile and ischemic and thin, then you have to be careful not that taking the retina in your probe. So here the setting will be different from retina that really shallow detachment will still having encounter pressure to get in the probe.
Okay, going back to the case, is my video showing now?
Not to me, not. No.
Not running.
It's not working, but it is there in the screen.
Not running.
Yeah.
Okay, well, I can try again. Okay, going back.
Fernando.
Okay.
Now I can see.
Now you can see. Okay, so progressing more in this case. So at this stage now, you can see it's almost 2 hours, and I'm starting to lose my patience here. Some bleeding happening, and then you start at this stage where you actually start to cut, and then maybe you're not very looking very clearly. The screen is moving. I mean the microscope is tilting, and then you kind of end up getting those breaks. My question is, at least in the new surgeon's experience, most of the times when you get the breaks are at these stages. When you're at the end, you're already exhausted with dealing with the high load that's sticky there, or what's your technique in dealing with those cases? I'm gonna ask Dr. Marco Mura to answer this question.
Can you hear me? Yes, it's open. Well, as Dr. Mortada said at the beginning, you really try to be relaxed until the end, because as you said, once you are exhausted, maybe it's time to take a deep breath and not panic once you see that the situation is going not in the right way. And if you really cannot remove all the sticky hyaloid, you can always try to maybe put some gas, try to flatten what you have, and then go back later if you really cannot do it. Because start panicking and start making breaks also is not the answer. Maybe I would have done that. Try to flatten it in some way, put some gas, not oil maybe, but some gas to avoid to have perisilicon proliferation. You know, if you left all the hyaloid and you put silicone oil inside, you will end up having a lot of membranes later. I like to use silicone oil in diabetics also, but I make sure that there is no vitreous left whatsoever. So if you are not having the vitreous detached completely, as in this case, and you are exhausted, maybe just put some gas and go back another time.
You know, silicone oil is not my preferred component in PDI.
Yeah, there's a question coming, and I will have your opinion on that. So just back to the polls, I'm going to ask about what's your preference in doing vitrectomy? What gauges are you using? I see, Dr. Mortada, you've shown a lot of cases using 23 gauge. Is this your preferred method of dealing with diabetic patients, or is it just something that you've just shown us today in the sake of the discussion?
I'm using both 25 and 23, but when I expect that I'm going to use scissors, as Marco said, I prefer the 23 scissors because it is more sturdy and more sharp. The blades are maybe a little bit longer, and so you can dissect radially across the adherent posterior hyaloid much faster with the 23 than with the 25, with the smaller blades. But with simpler cases, still with the use of bimanual, I may use 25. But in most of the cases that you asked me to prepare were difficult.
Yeah, I wanted to make sure that this is not a bias related to the timing of the discussion that we had.
Yes. So I prefer the 23 gauge. I would like to add about the use of phaco width. So I would like to ask you: do you use phaco-vitrectomy in patients with any amount of cataract, or as routine, or what is the indication?
So I will direct this to the panelists here. Myself, I tend to have a lower threshold of doing phacos because being an educational hospital, having resident and trainees with us would make us more inclined to do to give them the chance to do phaco. But I will also leave this for that. I just want to mention that after we've sharing the polls of the gauges that most of our attendees are using, it seems that 23 gauges is the most widely used here. I will ask Mr. Khaled to answer this question.
Can I make a comment, Del and everyone?
Welcome, Dr. Ayvala.
Thank you. I have been enjoying the presentation so much. I mean, the videos are fantastic, and I've been learning so much, and I'm so happy to be with you again in the Middle East and in KCASH. It's a real pleasure with all my friends. I really miss you guys. I just wanted to make a comment on the gauges. Remember that one of the things that we can do is to use, for example, a hybrid approach. We can use 23 gauge and then utilize a smaller gauge instruments if needed. So if you use 23, you can use the 23 cutter to do most of the anterior vitrectomy, do it in a faster and more efficient way. And then when you need to go for the membranes, if the cutter will help you with that, if there is enough space to go underneath the membranes and between the retina and the membranes, you can go with the 27 gauge cutter and do your work with that. So I like to use that combination, but then again, if you need to use another instrument that is only found on 23 gauge, then you have that advantage. Also with the 27 gauge cutter, you can get easier to the periphery if you need to at some point, if you have the 23 gauge cannulas instead of the 27 gauge cannulas. I also sometimes combine 25 and 27. So it's something to keep in mind that you don't have to just use one set, you can also combine.
That's very insightful. I think it's very nice way to do and choose between those armamentarium. I don't know if this is something that we how in terms of doing it in terms of in a setting of a hospital where you use one pack that you utilize all of the things that are available in the pack. How do you deal with that?
So at Wilbur, we have packs, of course, for 23, 25, and 27, but then we also have the cutters separately. And then the instrumentation that we need in addition to that comes separate. So we can do the hybrid approach in not a more costly way. I don't know if you guys can do it nowadays in KCASH.
I can say as of now, not, but I think Dr. Hassan Murtada had something to add there. Dr. Hassan?
Yes, for economical reasons, I think this may be feasible in the United States, but in Egypt, I think we have to limit the cost. So the best instruments for dealing with these complicated cases is to use either 23, which I prefer, or 25. But the hybrid technique may be useful, but you have to, but it will add more cost on the part of the patient, and it's a good idea, good technique, but
I understand.
You understand me, Fernando?
Absolutely, absolutely. No, I understand.
Okay, moving to the last question in the poll. It's about what kind of tamponade you prefer. I'm opening this question for everyone. And in this case, I ended up using silicone oil. And eventually, we removed it at a later stage and the retina was flat. So I'd like from everyone to participate in this poll. Moving on from this case, we have a lot of questions that's been asked, and I'm gonna start addressing them. I think the most important question was asked to Dr. Khaled AlSabti about when are the cases that you will choose to drain, and I mean, is there a size or a amount of fluid that will make you decide to do your technique?
Yes, there are so many factors. You have to consider, for example, I like to drain in a patient that is one-eyed patient that needs a faster visual recovery. I'm not a big fan of silicone oil. I think most of you are not. So I'd rather put gas rather than silicone. So in a case that you dissect very well, as I showed, you end up no breaks, and you don't need a long-acting tamponade, just put air. So that's where I want to drain. Any significant fluid, obviously, you have to drain. And the other reason why you want to drain, because you want to do laser also. If you end up having significant amount of fluid and you cannot perform full laser photocoagulation, and that may lead to more complications. You need to recurrence of bleeding, et cetera, et cetera. So it is sometimes very difficult to remove all the fluid in diabetics. We know that. We can leave some fluid at the end, and this will disappear in a week or two. But what I'm talking about is a significant amount of fluid that you don't feel comfortable leaving. We all know that this fluid will last for a long time. And every time you see the patient, get worried why this fluid is not going. I have patients, fluid stayed for 6 months. And every time I see the patient, I think twice, should I go to the operating room or not? So by just simply sticking a 27 gauge needle under direct visualization and removing most of the fluid, you cannot remove all the fluid. As Marco said, on the posterior ball, you will not. But once you start removing the fluid, some of the posterior ball fluid will go, the pressure difference will make it go towards the needle, and you will end up removing most of the fluid. So I drain any significant fluid. One-eyed patient, I needed a faster recovery.
So back to thank you, Dr. Khaled. Back to the results, it seems that we have mixed feeling about silicone oil. I have almost 41% of our attendees saying that they would do
I would like to ask
almost most cases.
the
Maybe
panel.
the way the questions were asked maybe is biased, but I would say that maybe we are using silicone oil more than we want to share.
I don't think, to my point of view, there is no really big risk of using silicone oil if you make sure the vitreous is gone. I mean, if there is no posterior hyaloid, I find silicone oil actually quite a good tamponade. You know, patients can move around. They can see. Most of our patients are monocular. They can fly out because they come from a lot over from the kingdom. If they bleed, maybe the macula stays free. If they get the detachment, maybe the macula stays attached. I mean, he has a lot of advantages. I don't think we should really demonize silicone oil because of complication. I think complications are related to the fact that before we were not really conscious of the posterior hyaloid schisis. That's why it was giving so many complications. Nowadays, if you are very careful in dissecting and you don't leave any vitreous, there is no risk in using silicone oil for that. I don't know what they think, the other people, you know.
I will add something to that. Be careful that when you have small tears that during related to dissections, the retina is mobile, and so that you can use gas rather than to go. But if you have very complicated and you have large breaks and the retina is stiff, so here it's difficult to put gas to make sure that your tamponade is the perfect. And the other factors, the patient positioning, patient traveling, all this is to be get in the decision.
Definitely. Dr. Arivalo, I'm very pleased to see you. It's been.
Thank you.
I'm happy that you shared your video. And
well, regarding gas and silicone oil, I prefer gas in most of my cases. I use silicone oil in cases that are very complex, as it was already described. And of course, patients that are monocular and have to travel. I get a lot of international patients, and they need to travel, and of course, silicone oil is the best option in those cases. Now, there are some diabetics that do develop a perisilicone preretinal fibrosis that is very, very difficult to peel afterwards, and those are a problem, but not all of them develop it. So that's why people don't like it in general.
I do want to ask you about the pre-op Avastin, because you are the one who can share the best experience in that. I have a lot of questions about it. So what's your recommendation in terms of timing, and is there any specific recommendation in terms of the amount or the drug itself?
Well, we use the normal amount in terms of concentration. We use 1.25 milligrams in 0.05 ml. And that is used 3 to 4 days before vitrectomy. And the reason of that is that in our studies, we found that about more than 80% of the patients that had a progression of development of a tractional retinal detachment occurred 5 days or later after the injection. So that is why it is the safest time to inject before vitrectomy. Now, it was mentioned that you could inject the day before on patients that are relatively avascular. So I agree with that. You can inject 1 day before, even on a patient that is vascular, and there's going to be some effect. I have colleagues that injected even the day of the surgery. Nathan Chaudhary from Canada has told me about his experience injecting the day of the surgery. And there is some effect. Of course, it's not the same effect as if you inject a few days before the surgery. So the important thing is not to wait too long before vitrectomy after the injection. I think that waiting a week is still reasonable, although some of those patients may progress. But the progression is only 3% of the cases, according to our studies. But 3% of those cases that progress do improve vision after vitrectomy. So it's not a complication that we should be afraid of if it happens. I think that we can help more patients through using intravitreal properative Avastin than the problem of tractional retinal detachment that may occur after you inject.
Definitely. Thank you very much, Dr. Arivalo. I have a question to Dr. Faisal about specific settings in using the Bush-Alam machine, the Stellaris, in terms of how you would do with the fold back technique. I see most of our other colleagues are using Constellation in their surgery. So people are very curious about your specific settings.
Well, there is no really specific setting, as I mentioned. I control everything from the foot pedal, and it depends where I am working. It depends upon the retina. If the retina is ischemic in diabetic patients, if there is retinal detachment or there is no retinal detachment. In fact, it doesn't depend. I mean, there is no specific setting that I can use for all patients. It depends upon the patient. This is it. And it depends what I'm using. If I'm using 25 or 23 gauge, there is no specific setting, you know.
I understand.
Yeah.
Another question to Dr. Murtada. It seems that you've shown most of your cases with ILM peeling. So is this your routine in any case where you have a TRD, or what makes you do the ILM peeling?
Well, I believe strongly that we have to remove all the scaffolds from the eye. I mean, the posterior hyaloid with the fibrovascular proliferation and the internal limiting membrane, especially in these difficult cases with a lot of proliferative tissue inside the eye. So we have to remove the posterior hyaloid. There is no doubt, and we have to do it. But regarding the ILM, I will regret not removing the ILM when I have proliferation over the macular area in the post-operative period. And in my experience, long and large number of cases, I have never seen a case of EP macular proliferation following ILM removal. And there is no harm from removing the ILM in these cases. It flattened the macula, it smoothened the macula, it removed the scaffold for reproliferation, and I think it has to be attempted. Some may say that is more difficult in diabetic patients because of the underlying retinal edema, but if you start from the optic disc, using it as a axis and moving to the periphery under PFCL, I think you can. And if there is an area where the ILM is strongly adherent, you can go to another area and start peeling the ILM. And at the end, you can remove as much of the ILM as required. So it has all the benefits for the long-term stability, anatomical and functional.
Dr. Marco, do you, you wanted to share your opinion on this matter as well?
No, I mean, I do ILM peeling, but not in every case. If I see there is some macula pathology, if I see there is some stria, or if I am not secure, for example, if I remove the posterior hyaloid, I want to be sure, I will stay and I will try to remove it. I don't see the need to do in everything, but I agree. I mean, I kind of, I sense what Hassan Mortada said. And, I mean, sometimes can be complicated also. Visibility is not great. So I don't do it in every case, but I mean, if you want to do it, I don't see anything against it. I mean, you don't see much of this posterior proliferation in a simple TRD. You usually see it when you have breaks and you have some PVR component, then you see it. In a normal TRD, if I'm sure I remove the whole hyaloid, I mean, I don't see the need if I don't see any macular pathology already present. That's my opinion, but I mean, there is no right or wrong.
A question, Dr. Hassan AlDhibi. When you have recurrent vitreous hemorrhage after vitrectomy, how do you usually approach these cases?
Well, this case is actually, I'm in the beginning, I starting with give 1 injections and giving them 1 to 2 weeks. If there is no obvious few happen, I get them back to the theaters and doing just only vitreous wash. This times I putting triamcinolone obviously to make sure that there is nothing that left in place. And then I examine the periphery because maybe an anterior fibrovascular, loops is there and perforations. So I trying to make more achieving for the peripheral vitreous and adding more lasers.
Okay, question to
and this time usually I tend to give to put some gas inside air.
Gas?
Using some tamponade like air or SF6 for these cases in the second surgery.
The question to all the panel, I don't know what's your preference here, but what should you, in which situation do you plan a vitrectomy in a macular sparing RD? Anyone wants to share their opinion here?
Yes, I can start. Yes, I think when one eye is lost because of unoperated tractional retinal detachment, and the other eye, I see that the macula is threatened. And this can be detected by doing serial of OCT follow-up for the patient. And if I notice that the macula is continuously becoming elevated and threatened, then I will do the surgery. Doing the surgery in traction retina detachment with the retina healthy is much better than waiting till the retina is ischemic, stretched, thinned out, and the prognosis when dealing with early cases, with late cases with ischemic thinned out retina. So in one-eyed patient, when the macula is threatened, the traction is increasing, ischemic changes start to appear, then I will do operate.
Back to technical questions in terms of the forceps and the scissors that you prefer. What about yourself, Dr. Faisal? Do you have a certain preference in terms of the the type of scissor that you use, the curved, the one that Dr. Marco was describing, or you like to use a straight? And the forceps, any specific forceps that you usually?
I use, as a forceps, usually I use the macular, the ILM forceps. Usually it's the Eckhart forceps. Regarding the scissor, I prefer always the curved. Always.
And what about if you're trying to peel the hyaloid? Do you use the retractable? I lost my word. The retractable loop to peel for peeling as well, or you use the Tano? What do you prefer?
No. I don't use Tano in the macular area. I mean, for the posterior hyaloid at all. I tend to use the back flush with silicone tip. It's very gentle. I can do it. Sometimes the posterior hyaloid is attached over the fovea. This is one of the reasons why I remove the ILM. In that case, I remove the ILM. Once I remove the ILM, I'm not a big fan of removing the ILM in all cases, just in specific cases I remove it. But if there is a lot of posterior hyaloid that attached over the fovea, then I remove the underneath ILM, then the posterior hyaloid will come along with the ILM. But I mean, otherwise, I mean, if it's outside the macula, I can do that with the cutter, by suction.
Okay, what about viscous dissection? Anyone here uses this technique? It was advocated a while ago, and then I
Fernando is the fan of that.
I used it a few times, but I'm not using it anymore. I use it very rarely.
Yeah, what I use is something a little different. More than viscous dissection is perfluorocarbon dissection. Is part of the armamentarium. And again, I want to make sure that it's clear that it's not that we can solve a complex tractional retinal detachment with just perfluorocarbon. What I do is inject perfluorocarbon on a small hole in the mid-periphery of the posterior hyaloid, and then inject it between the posterior hyaloid and the retina, and that detaches a lot of the posterior hyaloid in 360 degrees and all the membranes that are easy to be separated from the retina. But in most of the cases, I still need to use forceps, scissors, picks to complete the work, and the cutter, of course. And that's what we all do in our tractional retinal detachment cases. And I like to use bimanual techniques in most of the cases, unless it is a very easy case, and I use a chandelier. So we use everything that we have. But yes, perfluorocarbon dissection is one thing that I've been using for a long time now. And it helps because once you can inject it and dissect the vitreous to the periphery, it's very easy to dissect the vitreous completely from the eye, which is what you want. You don't want to leave any traction.
A question that I've been receiving a lot is about the chandelier. I would like each of you to say what's his preference in terms of what he would use. Do you use do you have your modified chandelier like the one you were using here? Do you prefer the one that's used by Alcon? A lot of people are asking about your preferences.
I use the 25 gauge chandelier from Alcon and the twin light from Dark.
Dr. Faisal, Dr. Hassan?
I use twin lights from Dark. And sometimes, as I showed in one of my videos, I put 2 twin lights. It doesn't mean that I put them on all the time. It depends where I work. And can switch off. I can switch it off from one side and move to the other. It depends where I work, but I prefer the twin light usually.
Anyone uses the lighted pick?
Yeah, I like it. I show you. I like especially peripheral manipulation. To detach posterior hyaloid is great, and it's also to lift some membranes is very good.
Yeah, I found our bullet lights that could be used. It's give you more, illuminations than the regular, dark types. But put in your mind, when I have complicated case, usually I create, one opening trocar in the nasal side so that I have 4, trocars in the eye, so that I have the chance to move all over and changing my situations up to the area that I'm going to dissect. So I get the light directed to the area where I have to see very well.
Okay. I think by this we basically concluded our discussion. We come almost at 2 hours here. And I would like to thank every one of you for participating in this session. I'm glad that we have Dr. Arivalo back here, at least virtually.
Thank you. Thank you guys very much.
Thank you for every one of you who participated with us today. Dr. Marco, if you want to add something.
Are you outside really, or is that a picture?
Virtual.
This is virtual. This is virtual. This is Hopkins on the back.
Well, thank you very much, everybody, for joining this this webinar. We are trying to organize this with Kekesh every week. Thank Dr. Adel for being always behind organizing everything and then moderating. And it was very nice to have you here, and hope to see you soon in another occasion. By the way, actually, next week, Faisal, you can say it. Next week, there is another webinar. Can you please announce?
Oh, yes. We have a webinar on the 17th of May titled, I think,
Challenges.
The title is important.
Sorry? Challenges in vitreoretinal surgery. It's an open panel that will be discussed different videos. It's a video panel by distinguished invited speakers. We hope that all will join.
Inshallah. Thank you, everybody, and stay safe.
Thank you. Thank you.